Bismillahirrahmanirrahim. Let's begin with the quote of the day. Sometimes life doesn't give you what you want, not because you don't deserve it, but because you deserve more. Today, I'll be presenting my presentation on malaria. I'll be giving this presentation under the kind supervision of my most honorable supervisor, Professor Dr. Saira Afzal. Learning outlines for today are introduction, epidemiological determinants, chain of transmission and communicability, clinical manifestations, levels of prevention, recent advances, and MCQs. Learning outcomes. By the end of the presentation, participants will be able to understand the epidemiological determinants of malaria, clinical features of malaria, national and global malarial prevention strategies and updates. Problem statement. The key facts are, in 2020, there were an estimated 241 million cases of malaria worldwide. Malaria is a life-threatening disease caused by parasites that are transmitted to people through bites of infected female Anopheles mosquitoes. It is preventable and curable. The estimated number of malarial deaths stood at 6,27,000 in 2020. The WHO African region carries a disproportionately high score of global malaria burden. In 2020, the region was home to 95% of malarial cases and 96% of malarial deaths. Children under 5 accounted for about 80% of all the malarial deaths in the region. Now, the problem statement in Pakistan. Pakistan is considered as a moderate malaria endemic country, but still 177 million of individuals are at risk of malaria. Roughly 60% of Pakistan's population live in malaria endemic regions. Introduction. Malaria is a mosquito-borne febrile disease caused by malaria parasites. Malaria, mala means bad and area means air, is a protozoal infection, a disease caused by members of the protozoan genus Plasmodium. Parasites affect the human liver and red blood cells. Humans are infected with Plasmodium protozoa when bitten by an infective female Anopheles mosquito vector. Symptoms may appear within weeks to months or even years. There are 4 species of malarial parasites: Plasmodium falciparum, Plasmodium vivax, ovale, and malaria. Now I'll be presenting a case study of malaria just for the better understanding. A 67-year-old female Western Africa initially presented to the emergency department. Patient had returned 5 days ago from her travel and started to develop symptoms of fevers and fatigue. Patient denied any immunizations received before traveling. Patient complained that her fevers were associated with headaches, chills, rigors, or the chest pain. Patient had WBC count of 12.6, HP 10.7, hematocrit 30.6, blood urea nitrogen 12, creatinine 0.3, and blood glucose of 291 consistent with diabetes. Blood smears were positive for Plasmodium. Patient was started on quinine 648 mg and doxycycline 100 mg, and IV fluids were given. The probable diagnosis is the index of suspicion for malaria was high as patient had recently traveled from an endemic region. Patient's travel history to Western Africa and the presenting symptoms also made us consider a possibility of Ebola virus disease. Specific risk groups for malaria. Our study also shows a high prevalence of malaria in the age group more than 14 years, which is consistent with other studies in Pakistan and India. We also found a high prevalence of malaria among females than males, which is similar to another study but differs from other studies, non-immune pregnant women. At a global level, the most vulnerable age group to malarial deaths are children under 5 years of age. In 2019, they accounted for 55% of total deaths. Now the triad, the epidemiological determinants. The agent factors are Plasmodium species. Vector characteristics are these are the mosquito characteristics. The environmental factors are the economic, geoclimatic, political-legal, socio-cultural, and public health intervention. Host factors, genetic makeup, immunological makeup, and the human characteristics. Agent factors, malarial parasites, Plasmodium, reservoir of infection is a human reservoir. Type of species of the parasite and the incubation period accordingly are, for the falciparum malaria, it's 12, 9 to 14 days. For the vivax, it's 8 to 17 days. On average, it's 14. And for the ovale, it's 17. And for the quadrant malaria, it's 28. That is 18 to 40 days. approximately. Relapses. Plasmodium vivax and whale malaria trend to relapse more than 3 years after the patient's first attack. Recurrence of falciparum usually disappear within 1 to 2 years. Plasmodium malaria has a tendency to cause prolonged low-level asymptomatic parasitemia. Environmental factors. Seasonal disease, it's from July to November. Man-made malaria, burrow pits, garden pools, irrigation channels. Vector of malaria in Pakistan is A. Kilsifacius and in the rural areas and A. stephensii in the urban areas. Mode of transmission. Malaria is caused by a type of microscopic parasite that's transmitted most commonly by mosquito bites. The ways for the other transmissions are from mother to unborn child through blood transfusions and by sharing needles used to inject drugs. Now, the signs and symptoms, they include headache, fever, sweating, chills, fatigue, pain, dry cough, enlargement of spleen, back pain, nausea, vomiting. So the code that the mnemonic that is used is the falciparum, that is fever, that is black water fever, ARDS, low blood sugar, cerebral malaria, infections, pulmonary edema, anemia, renal failure, urine output decrease, and metabolic acidosis. Surveillance. Improved surveillance of malarial cases and deaths helps ministries of health determine which areas or population groups are most affected and enables countries to monitor changing disease patterns. Strong malarial surveillance system also help countries design effective health interventions and evaluate the impact of their malaria control programs. Now, the classification of malarial cases. So, if there is a parasitologically confirmed malarial infection, then it is divided that either it is because of the mosquito-borne transmission, and if not, then it is due to the mosquito. If not due to the mosquito-borne transmission, it might be induced, for example, because of the blood transfusion or the congenital malaria. So, if it is because of the mosquito-borne transmission, then either it can be acquired abroad or outside area, or either it's acquired locally. If it is acquired, then it can be imported, and if it's acquired locally, it is either introduced, either indigenous. Ultimately, it leads to the relapsing phase or the recrudescent phase. If it is relapsing, a history of Plasmodium vivax or Plasmodium ovale infection within past 3 years, no epidemiological vicinity. And in the recurrence phase, in the recrudescent phase, there is a recurrence of asexual parasitemia of the same genotype that caused the original illness due to incomplete clearance of asexual parasitemia after the anti-malarial treatment. Now, the measurement of the malaria. So there are pre-eradication area, and the vector indices. First, there is pre-eradication area. So in that, the magnitude of malaria was determined based on the diagnosed cases. The classical Malariometric measures are spleen rate. Number 2 is the average enlarged spleen, and number 3 is the parasite rate. The spleen rate is the percentage of children between 2 and 10 years of age showing enlargement of spleen. Average enlarged spleen, this is a further refinement of spleen rate denoting the average size of the enlarged spleen. It is a usual Malariometric index. Parasitic rate, percentage of children between the ages 2 and 10 years showing malaria parasite in their blood film. In the eradication area, the microscopic diagnosis of malarial causes became the main method of diagnosis. The parameters used for the measurement of malaria were mostly parasitological in nature. The following parameters are employed: A. Annual parasitic index. B. Annual blood examination rate. C. Annual falciparum incidence. D. Slide positivity rate. And E. Slide falciparum rate. Annual parasite incidence is the confirmed cases during 1 year divided by population under surveillance into 1,000. Annual blood examination rate is equal to the number of slides examined per population into the 100 population, divided by population into 100 population. And then there's annual falciparum incidence, a slide positive rate, percentage of slides found positive for malaria parasite irrespective of the type of species. Slide falciparum rate is the percentage of slides positive for the P. falciparum parasite. Vector indices. A malaria survey is not complete unless it induces investigations relating to the insect vector. Some of the important vector indices are human blood index, sporozoite rate, mosquito density, man biting rate, and the inoculation rate. Now, the prevention and control. Primary prevention. These interventions are designed to prevent the onset or further incidence of a specific problem. Secondary prevention is an early intervention that decreases the prevalence of a specific problem. Tertiary prevention, treatment designed to improve quality of life and reduce the symptoms after a disease or disorder has developed, does not reduce the incidence or the prevalence. The prevention control, so the primary prevention is basically health education, environmental modification, and the acute intervention measures. Acute intervention measures include certification of the problem, essential feature of planning and development of a sound control strategy to maximize utilization of available resources, provide guidelines as to which strategy could be most suited. Vector control, the two core interventions are insecticide treated nets and the indoor residual sprayings. According to the latest World Malaria Report, 78 countries report mosquito resistant to the least one of the four commonly used insecticide classes in the period 2010-2019. In 29 countries, mosquito resistance was reported to all main insecticide classes. Vaccine. Since October 2021, WHO also recommended broad use of the malarial vaccine, trade name Mosquirix, among children living in the regions with moderate to high P. falciparum malaria transmission. The vaccine has been shown to significantly reduce malaria and deadly severe malaria among young children. Due to the low efficiency, the WHO does not recommend the routine use of the vaccine in babies between 6 and 12 weeks of age. Chemoprophylaxis of malaria. The recommended prevention method may be mosquito bite prevention only or mosquito bite prevention in combined with chemoprophylaxis and or standby emergency treatment. Preventive chemotherapies includes chemoprophylaxis, intermittent preventive treatment of infants and pregnant women, seasonal malarial prevention, mass drug administration. These safe and cost-effective strategies are intended to complement ongoing malarial control activities, including vector control measures, prompt diagnosis of suspected malaria, and treatment of confirmed cases with anti-malarial medicines. Secondary prevention. So the diagnosis of malaria, either the microscopic or microscopic diagnosis is via the blood smear, the fluorescent microscopic, and the quantitative Buffy-Core. Antigen detection, the immunochromatographic dipstick, RTT. Serology includes IFA and ELISA, and the molecular diagnosis includes PCR and the real-time PCR. Two types of blood film for the malarial parasites includes thick blood film, thick blood smear. It is used to determine if parasite is present, and the thin blood smear, which is used to confirm the Plasmodium species if they are present or not. Treatment of malaria in Pakistan. Treatment of uncomplicated malaria in adults, excluding pregnant women. So for the Vivax malaria, if there is slight positivity or clinically diagnosed case, so the treatment includes chloroquine, that is 150 mg base tablets at day 1, 2, and 4. These will be given in a quantity of in a dosage of 4 tablets per day. So primaquine is 15 milligram base tablets, and that is 1 tablet a day for 14 days. For the falciparum malaria, the radical treatment includes sulfadoxine and the pyrimethamine. Sulfadoxine pyrimethamine tablets, which is 500 mg plus 25 milligram tablets, plus the artesunate 50 milligram tablets. At day 1, 2, and 3, they will be given accordingly. The artesunate derivatives and the partner medicines of these should not be given as monotherapies and should not be available as monotherapies. Treatment of malaria in children. Severe malaria immediate referral to hospital, clearing the airways in unconscious patients, giving one of the following pre-referral treatment options. That is A, artesunate or artesunate 10 milligram per kg by the rectal administration. B is the injection artemether, and C is the quinine intramuscular 10 mg administering the anticonvulsant in patients with convulsions. Approaches and strategies of malaria control in Pakistan. Malaria control activities are on-ground since the formulation of health services provision fundamentals outlined in a Bohr's Commission in the subcontinent and in Pakistan. These are functional since 1950s through succession of different approaches. Owing to the two major failure in the endemic countries control programs in 1998, Rollback Malaria initiative was coordinated and strategy by WHO, UNICEF, UNDP, and the World Bank. Pakistan, being the signatory to the effect, started rollback malaria implementation in the phased manner by marking to 73 million. Under 18th Amendment in the Constitution, Federal Ministry of Health, along with its attached department, including Directorate of Malarial Control, were developed on 13 June 2011. Malarial Control Strategy Plan Pakistan 2015 to 2020 at a glance. The goal was to decrease it by 2020. We have to reduce the malaria burden by 75% in high and moderate endemic districts, agencies, and eliminate malaria in low endemic. So it had objectives, and then it had outcomes and impacts as well. Rollback malaria control added as initiative was launched by WHO, UNICEF, UNDP, and World Bank in 1998. Aim was to reduce the deaths and incidents to 75% by 2015. The strategy, the rollback malaria strategy, included early diagnosis and prompt treatment, prevention by the insecticide-treated malaria materials, vector control measures, indoor spraying, larvicide environmental management, prevention of malaria in pregnancy, monitoring for epidemics, rapid response, new methods and tools, improvement and in existing tools through research and development. Coordinated actions through establishing a partnership that utilize an optimal mix of measures adapted to local situations. Why did rollback malaria fail to achieve its goals? Due to the weak WHO leadership, dysfunctional partnership, and the wrong technical policy, a lack of clear strategy, limited technical expertise in countries and internationally, no effective monitoring and evaluation. WHO's global efforts to control and eliminate malaria is via communicating and promoting the adoption of evidence-based norms, standards, policies, technical strategies, and guidelines. Number two, by keeping independent score of global progress. And number three is by developing approaches for capacity building, system strengthening, and surveillance. And number fourth is by identifying threats to malaria control and elimination, as well as new areas for action. Elimination. Malaria elimination is defined as the interruption of local transmission of a specified malarial parasite species in a defined geographical area as a result of deliberate activities. Continued measures to prevent re-establishment of transmission are required. In 2020, 26 countries reported fewer than 100 indigenous cases of a disease, up from 6 countries in 2000. So the countries that have achieved at least 3 consecutive years of zero indigenous case of malaria are eligible to apply for WHO clarification of malaria elimination. Since 2015, 9 countries have been certified by WHO. A Director General as malaria-free, including Maldives, Sri Lanka, Uzbekistan, China, Argentina, and so on. WHO framework for malaria elimination. So the WHO response against malaria, the WHO Global Technical Strategy for Malaria 2016 to 2020, updated in 2021, provides a technical framework for all the malaria endemic countries. The strategy sets ambitious but achievable global targets, including reducing malarial cases incidence by at least 90% by 2030, reducing malaria mortality rates by at least 90% by 2030, eliminating malaria in at least 35 countries by 2030, and preventing a resurgence of malaria in all countries that are malaria-free. So the Global Technical Strategy for Malaria 2016-2020 is basically the WHO strategy was developed in close alignment with the Rollback Malaria Partnerships Action and Intervention to defeat malaria 2016 to 2030 for a malaria-free world to ensure shared goals and complementarity. The principles included that all the countries can accelerate efforts towards elimination through combinations of interventions tailored to local contexts. And number 2 is the country ownership and leadership with involvement and participation of communities. Number 3, improved surveillance, monitoring, and evaluation. Number 4, equity. Number 5, innovation in tools and implementing approaches will enable countries to maximize their progression. Malaria elimination reflected in the Global Technical Strategy for 2060 to 2030 had pillars and supporting elements. The pillars included ensure universal access to malaria prevention, diagnosis, and treatment. And the pillar 2 included accelerate efforts towards elimination. Pillar 3 included transform malaria surveillance into a core intervention. The supporting element 1 was harnessing innovation and expanding research, and supporting element 2 included strengthening the enabling environment. So the GTS vision, goals, milestones, and targets are mentioned here. So the goals The third goal, the goal number 3 includes the elimination of malaria from countries in which malaria was transmitted in 2015, and the fourth includes the prevention, reestablishment of malaria in all countries that are malaria free. It has milestones and targets as well. Recent updates. So the chloroquine-resistant Plasmodium falciparum in Pakistan, the article said the poor or presumptive diagnosis by unattained lab personnel who can misdiagnose P. falciparum and mixed infection lead to the improper medication. The migration of Afghan refugees and other internal displacement of people from war zones and highly endemic malaria areas to the other parts of the nation present challenges for surveillance. The massive amount of agricultural land available for mosquito breeding sites, the scarcity of insecticides and the bed nets, and the people's reluctance to use them, and poor sanitation and stagnant water impede elimination. Pakistan seems to be entering an age advanced during resistance in which monotherapies are essential preventive measures that are ineffective for confronting the mutant malarial species. Policymakers should consider this overlooked pattern of malaria when reformulating P. falciparum control. Initiating research projects to gain detailed insight into drug resistance genes through random sampling of endemic areas, otherwise malaria in Pakistan. Another article is the mapping genetic markers of artemisinin resistance in Plasmodium falciparum malaria in Asia, systematic review and the spatiotemporal analysis. The study aimed to develop. There was a steady increase in the prevalence of WHO validated K13 markers, with the lowest of 4.3% in 2005 and the highest of 62.9% in 2018. Overall, the prevalence of the gene, the CYS 580 TYR mutation. This study aimed to develop up-to-date spatial distribution visualizations of K13 gene markers of artemisinin resistance in P. falciparum for policymakers. Now time for MCQs. MCQ number 1, malaria is endemic in many countries and is reported to be a leading cause of deaths from parasitic infection, killing millions of people globally. The greatest number of deaths occurring in Africa. Which of the following age group of the people have a high death rate? A, 10 to 15 years of age. B, more than 5 years of age. C, less than 40 years of age. D, 10 to 25 years of age. E, 20 to 30 years of age. Anyone? It's P. Number 2, which of the following statement is regarding prevention of malaria is true? A, combination of preventive measures is most effective. D, DT is still commonly used to kill mosquitoes. C, locally preventive technologies like nets are rarely effective at limiting bites. D, the preventive measures are not very effective in case of P. falciparum. And E, a combination of preventive measures is not effective. A combination of preventive measures is not effective. E. Number 3, all following statements regarding recurrent malaria, relapse, recurrence, and the infection are correct except A, some patients develop malaria again after a period. B, recurrence is due to the insufficient treatment. Relapse is due to the reappearance of merozoites from the hypnozoites. And C, it can be seen in all Plasmodium species causing malaria. D, the highest rate of relapses occur with malaria caused by P. vivax, and E, none. The answer is C. Fourth, a person can develop severe infections when infected with P. falciparum. The parasites grow and infect many RBCs and liver cells, and in severe cases may even invade the central nervous system. The malarial complications can lead to the hemolytic anemia, and symptoms like jaundice, discoloration of the urine can be seen. Which of the following term has been applied to this type of complication caused by P. falciparum? A, the valley fever. B, yellow fever. C, black water fever. D, kala azar, and the E, hemorrhagic fever. The answer is C. Number 5, the malaria drug hydroxychloroquine was falsely reported to be effective in which type of viral infection in 2020? A, dengue. B, influenza. C, COVID-19. D, swine flu. E, hepatitis. The answer is C. In 2021, WHO has recommended the first ever vaccine against malaria, which the following age group of the people can get the dose of the vaccine who are living in the malaria epidemic regions. A, children 5 months to 10 years of age. B, 15 years and older. C, 60 years. D, infants only. E, adults only. The answer is A. Number 7, thin blood smears film for malarial parasites is used to determine malarial parasites presence. B, to confirm the plasmodium species. C, malarial parasites absence. D, parasites presence and confirmation of plasmodium species. And E, the malarial parasites absence. It's B. Number 8, which of the following symptoms are the most common in people who are infected with malaria? A, muscle aches and low-grade fever. B, skin rashes and swollen legs. C, mouth rashes and itchy skin. D, high-grade fever and chills. E, fever allergy. The answer is D. 9th, treatment of uncomplicated P. falciparum malariae is in adults, excluding pregnant women, is tablet chloroquine. B, tablet primaquine. C, tablet sulfadoxine, pyrimethamine, and artesunate. D, tablet quinine, and E, tablet diquinine. The answer is C. Number 10, the development of malarial vaccine has faced several obstacles: the lack of traditional market, few developers, and the technical complexity of the developing and vaccine against the parasite. Vaccination against malaria is not successful because A, it does not provide antibodies or antitoxins. B, plasmodium produce minute bodies. C, plasmodium produce antitoxins. D, plasmodium virus is vulnerable to heat. E, plasmodium virus is not vulnerable to heat. The answer is A. Here's the key of the MCQs. Thank you so much, everyone. And here's the YouTube link of the channel. Please like and subscribe all the videos here.